for putting into perspective diagnostics and the value of diagnostics is not always clear to people, and that was a great scene setter from my point of view and what I want to say here. In the earlier session, the one just before this, whenever anybody spoke about the diagnostics industry, I didn't exactly feel the warmth. It doesn't seem like we're the most loved people around here. I'm probably going to try and change that. Although don't look to me to defend the rest of the diagnostics industry. So we're going to talk about...
Just say, I think Cepheid is a great company.
You're too kind. You're going to hate me because I've invested in Gilead as well. So.
Oh, right.
Oh, yeah.
Okay, well, we'll come to that later maybe. We'll talk about Xpert MTV Riff, which is a particular example of what we consider to be particularly smart aid. So, what does it do? I'll just briefly go through these slides. I won't talk every line. But in 2006, if you wanted to diagnose TB, active TB, you had two ways really. One was a sputum smear microscopy, which requires a certain amount of skill. Doesn't take too much time, but the sensitivity is around about 50%. So you leave the other 50% out there infecting other people, which is kind of not what you want to do. Second option is liquid culture, which will give you around about 100% sensitivity, as it's the gold standard, it should do. But it takes up to 4 to 6 weeks to get a result, and then an additional 2 to 3 weeks to get a result for rifampicin resistant to know if your patient can be successfully treated with first-line drugs. In 2009, this changed. Now, I use the word revolution not just to try and blow our own trumpet, but it was a word that was used at the time by the head of the Stop TB campaign, Mario Raviglione. This brought in place a test which worked as quickly, if more quickly than sputum smear microscopy, with the level of sensitivity one expects from culture, but it does it in 2 hours or so. And at the same time gives you a result for rifampicin susceptibility. So you've got a clear guide on therapy. And it's all done in that little cartridge on the right-hand side. When we talk about aid, we're either going to pump money in to buy the same old tools and expand our programs, but when those tools aren't working, you need something new. And WHO recognized way back when, in 2006, 2007, that it needed new tools if it was going to get on top of TB. The red dots show the ones that they had at that time, and the next one, which that's scheduled for 2010, was automated nucleic acid amplification test, detection and diagnostic susceptibility testing, or drug susceptibility testing. And that was this product. That was what they wanted. There was a chemistry out there. I come back to the question about science and technology. This is science. This is just science. This is knowledge. So then, in 2001, I think it was, David Alland had published on a particularly interesting chemistry. Normally when you do a molecular test, a diagnostic molecular test, you've got 2 primers, a pretty short amplicon, and a probe. Okay? He looked at it differently. He amplified the whole rifampicin resistance determining region of Mycobacterium tuberculosis, and he tried to put 5 probes on it. So if all 5 probes hybridize, that's a wild type susceptible strain. If 1 or 2 do not, as we see here, then that's indication of a mutation underneath that probe. Okay, that's the basic chemistry. That looked good. So the Gates Foundation targeted an organization called FIND, the Foundation for Innovative New Diagnostics, to find a partner for that technology. And they settled upon Cepheid as having the most likely technology to achieve what they wanted to achieve, which I'll show you in a second. Cepheid was known because you heard talk earlier on of the anthrax that was posted to the senators in the United States. Well, Cepheid was brought in by the United States Postal Service to provide a system to detect anthrax on the postal sorting lines. Now, this wasn't to protect senators. It wasn't even to protect the wider public in the United States. But because of the unionization of the postal workers, it was brought in to protect them. Okay? So we developed a test for anthrax. Fortunately, we never detected it, otherwise there would be major panic. So the target product profile for this was that it should be as near patient as we can make it. It should be easy to perform, it should be safe to perform, because performing a smear test is dangerous. You create aerosols as you make the slide, and so the user is placed in danger. It should be rapid. It should be as sensitive as culture, it should be as specific as culture. It should detect rifampicin resistant, it should be robust, and it should be stored at room temperature, where room temperature can be above 40 degrees centigrade. So no big ask, eh? I mean, this was in the era of molecular diagnostics where everything was frozen. And we're supposed to do this. Well, needless to say, we did it. But one of the things that kind of made us want to do it was that, talking about really smart aid again, FIND and the WHO got together and they produced an exceptionally comprehensive market report. So they were appealing to Cepheid and other diagnostic companies at a level that they understand. Normally something like this would cost you, well, $10,000, $20,000 easily. They were giving this away, and this was the best one I'd ever seen. So that was enticing us in one way. The other thing was there was finance on offer. I got the impression people think that industry is greedy. But one thing industry is more than greedy is risk averse. And what this does by bringing in finance, it lowers the risk of a failed product and encourages companies to take it up. So you see, industry is quite predictable in this way, and Bill Gates knows how industry works. So I got a message saying, well, there's no market for this in the United States. Nobody gets TB in the United States. If it's going to work, it has to work in Europe. So the deal here is that we sell at a high price in Europe, and the countries that depend on Europe, and we can sell at a low price elsewhere in the world. So the 145 countries deemed to be high burden by the WHO. So he said, okay, we'll go out there and look at the market. And so the marketing team from the US said, well, you'll have to do that. And by the way, the chief exec really would like to work with Bill Gates. So I was between a rock and a hard place. But we decided we'd go with this. And so in 2009, note the date. The publication was 2001. We were asked to do this in 2006. Okay? 2009, we had a product. That's a big difference. This is now technology. This is something you can use and produce results with. This is not just airy-fairy knowledge and science. Okay? To make it easy to use and to protect the user, they just have to add a buffer to a sample, close the lid, swirl it around a bit, leave it for 10 minutes on the bench, mix it again, leave it for another 5 minutes, and then put it into the cartridge, and that's it. So we can train people to do this in about an hour. In 2010, these were a few milestones. There was a New England Journal of Medicine publication on this assay, which published the results of the field studies, because we had to prove to WHO that this is a worthwhile product. End of 2010, it was endorsed by WHO. In 2011, WHO published a guide to rapid implementation. 2013, a Cochrane report published, plus an expanded guide to utilization of the product by WHO for use for samples other than sputum. I know this is about inequality, so I thought I'd throw something in about inequality. There was inequality of access to this technology. In 2010, 145 high burden countries and low income countries had access to this technology. Not until 2013 did the United States have access to the technology, even though it was manufactured there. And that's really down to regulatory authorities. So there's some thinking to be done around that if we want universal access. I haven't said much about Xpert, but it's a totally modular system. You can see all these modules in the boxes. So this is the one that's most widely used around the world. It has 4 different modules, each one of which can be doing a test. And it can be a different test. It doesn't have to be TB. It can be TB, it can be HIV next to it. Totally random access. But the technology itself, we believe, lends itself to working at the cellular level, chromosome level, all sorts of genotypic analysis, but also proteins. Ultimately, we will introduce immunoassays within the cartridge where it makes sense. One place it might make sense is with Clostridium difficile, where we might be wanting to look for the presence of the organism, but also the host response. So FIND put this together for us, and working with NIAID and Cepheid, they funded the program. It cost something like $35 million total to get this product to market. FIND put together the validation studies, and Cepheid ourselves, we set up 2 channels of distribution, one commercial, and then we split off another group for compassionate sales. That's the group that I work for. And we try and keep our overheads low, and we try and keep our people small as well. So what we've managed to do is keep a lid on the costs, which means we can keep the price of the system down to $17,000 instead of the commercial $65,000 it would cost for a 4-module system. And the cost of the test started out at $22 a test instead of the $50 that it normally sells for in developed countries. Over time, we brought that down to $16.88 because we had an agreement with FIND and WHO that as volumes rose, the price would go down. But in order to make a big jump, or a big downward jump in price, there was what we call the buy-down in 2012 by a group of funders, PEPFAR, UNITAID, and the Gates Foundation, in which they said, we will give you this amount of money, which is effectively 3 million tests. That means you can produce 3 million tests this year, which ought to make it self-sustaining. And then all you have to do is sell 3 million tests a year. So that, again, was an extremely innovative way forward of making these things sustainable. Because it doesn't work unless the company sells products at a price above its manufacturing cost. One of the things about working with WHO and other funders is they want to know where the money goes and they want to keep a careful eye on you. So WHO monitors the countries in which the systems have been shipped. So every quarter we send them data. So they know where the systems have shipped, where the modules are, how many cartridges have gone into the different countries, and you can see the curve is significantly exponential. Oh, I'm glad you put that side. TB community, very rapidly, is quite complex. These guys put in the money, these guys then put together the programs and organize these people into groups to make the thing work, to make the dynamic go forward. So these guys oversee the national program activities and essentially perform pilot projects, because the idea here from the funders is to put a pilot project out there to show a national government that the technology will work, and then the national government is meant to take over funding thereafter. On that side you have WHO pushing the thing forward. On this side you have the advocates, who are a total double-edged sword. They can be good to you or they can be very unpleasant. I won't go any further into that unless we want to discuss it later. The issue is you want to measure impact. That is very, very difficult at this stage because the systems have not adapted to having a much faster test. So getting the result to the patient, getting the patient on treatment is not moving forward as fast as it ought to. But what we can see is that there is a greater number of microbiologically confirmed cases now, a lot more MDR being detected, and more HIV being detected too. Okay, just quickly going forward, there are other things in the pipeline, other products out there already. Xpert's a platform, and it performs multiple different tests. Some are already out there, and the ones in the middle there are out there at concessionary pricing. Last slide. Next thing that's going to happen is in Q4, the software is going to be changed such that we will have a cloud-based system for collecting data, allowing pretty much instant epidemiology and oversight and monitoring and evaluation of programs. And for that, I thank you very much for your patient attention.
An excellent talk, came to time, and I hope you're feeling some love from the